time of COVID. We have several speakers who are going to contribute this evening, and then there'll be some time for discussion at the end. It'll be really important to keep all mics on mute if possible when not contributing, just to make sure the sound is as good as possible. And I'm going to introduce our speakers, who are Paul Flynn, Zoe Fritz, when she's able to join from some slight technical challenges, Ben Clark, Phil Sharkey and Rob Tobin, who will perhaps introduce themselves as they each contribute as we go. So without further ado, Paul, I'll hand over to you first of all, and then, as I've said, we're all hoping that Zoe will be able to join us imminently.
We're hitting another technical difficulty because I see I'm in the attendees group rather than the participants group, and so I can't share my screen. Have I replied to the wrong invitation?
It's fine, Paul. I've just updated your
Brilliant.
You should now be able to share.
Lovely. We'll just give Zoe another minute or two to see if she can join, because she is rather central to the opening part of this presentation.
If any of the other speakers have Zoe's mobile number, I'm assuming you might have already dropped her a text saying that.
She's just joined us again. I can see Zoe is just joined. Or has
yes,
it
no,
dropped?
I've managed to link it to my phone. I think someone was trying to call me on the phone at the same time, but I've hotspotted. Hello, everyone. Apologies.
No problem. Paul's just going to kick off, Zoe. So perfect timing.
So, oh goodness, press the wrong button. Well, good evening, everyone, and thank you, Justin, for giving us the chance to speak this evening about the experience of setting up the Clinical Ethics Advisory Group at Addenbrooke's. And I thought I'd just start by outlining the aims of the group, which is, as stated in our terms of reference, to support trust staff in decision-making based on ethical principles and reasoning, to provide an ethical input to decision-making related to patient care, whether at management or clinical level, and to promote clinical ethics education within and beyond the trust. And the format of the presentation, which is going to be pretty informal this evening, there won't be that many slides, is that Zoe is going to talk to us about the gestation of this group and set it in its national context of how ethics is increasingly important in the delivery of clinical care. Myself and then several of the other members of CUH will talk about the delivery. Zoe will then talk a little more about our plans for developing things further. I will conclude with a brief summary, and I'm hoping that we'll have at least 20 minutes for questions and discussion at the end. So without further ado, Zoe, over to you.
Thank you. So it's very nice to see many of you here and your names coming up on the side. It's always a little bit weird to talk to screen, but I obviously know many of you, and I'm really grateful to Justin for inviting us to talk about this, because our Clinical Ethics Advisory Group. Paul, do you want to put yourself on mute?
Yes, and I'm not quite sure how to stop sharing my screen, but.
Well, I need, okay.
You're not sharing at the moment, Paul. We can't see any slides, but
No, but if someone could allow me to be able to in a second, that would be great. I can see I'm currently not able to. So I'll chat for a sec, but hopefully my share bit will appear in a sec.
Thanks, Tony.
Thanks. That would be great. So anyway, I was saying a great opportunity to talk about how it is that we have built this up. And as Paul says, he's going to talk about some of the cases we've had. But I'm hoping that this is an opportunity for those who haven't used the Clinical Ethics Advisory Group before to learn what we could do and to tell us what we could do in addition to what we're already doing, and really kind of kickstart maybe the next chapter. So I think there's a little bit of history that is probably relevant. So Cambridge Addenbrooke's used to have a clinical ethics forum. And in fact, when I was a registrar, I was a member of this clinical ethics forum, which was very interesting. And we would have very interesting conversations and we would not make any progress with any of it, if I'm entirely honest. So I was a junior doctor, member of this. There were lots of erudite people on it, much as there are now, but there wasn't really a structure for us having conversations. And people would bring problems, often not in an urgent manner, but in a, we wonder if someone else could give us some advice. And there would be quite a lot of chin scratching and discussion, and as someone said to me, as many question marks as full stops. So, oh, what would be the best thing to do here? And what are the interesting questions? And what would a patient think? And I kind of it lent itself to a lot of circular discussion. And unsurprisingly, there wasn't an awful lot of urgency with which people brought things to these to the old clinical ethics forum, because there wasn't a clear outcome that came from it, so that people weren't getting things very much back. Anyway, it slowly dwindled, and then we were in the unfortunate position of being the only Shelford Group hospital that didn't have a clinical ethics advisory group. And so during COVID, it became obvious that there were some serious ethical questions that we needed to answer. And I'd been kind of, I think, gently pushing is probably a polite way of saying that we needed to have some system in the hospital. And COVID gave an opportunity to say we really need this now. And so we had the support of everybody in setting it up. And one of the things that we were determined to do was make sure that in saying that we're going to have a resource for clinicians to come to with their ethical problems, we're also going to have a structure in order to be able to deal with those problems, and we're going to have some kind of outlet. Paul is going to talk to you shortly about our application form for dealing with ethical issues, and how people can bring things in a structured way and the merit of that. But the thing that I wanted to talk about was then some structure that we've come up with in terms of how we might address some of the problems. And I can see that Julian Huppert is on the call. He chairs the system-wide ethics committee, which is across Cambridge and Peterborough, and includes membership from all of the inputs, all of the Cambridge and Papworth and the Mental Health Trust and all the rest of it, so that we can then talk about how ethical issues go across the system. And he was involved as well in this checklist that I'm about to share with you, which hopefully I can see I have been gifted sharing potential. My internet is now holding up, so all is hopefully going to work. That's the referral form. There we go. Now, are you able to see something? It says I'm presenting, but I can't see anything.
We can see a black screen at the moment.
Presenting ... Okay, I'm going to stop presenting that. I'm going to just share my whole window and go to it that way. Let's see if this will work. Right, can you see this instead? Can you see ethical policy and decision making?
No, we can see
Oh,
pictures of the screen of the individual attendees.
look at that
Now
now.
we can see it. Yep, that's it.
Great, okay, excellent. So as I said, we wanted to come up with something that meant that there was some kind of structure in how we address these problems, and also then some kind of structure in how we fed back. And some of this may seem very obvious, and I'm very aware that as an ethicist, sometimes people think that the kinds of things I do are just straightforward and common sense, and there is absolutely an element to that. I do not deny that there is something straightforward and common sense about thinking about what is the right thing to do and thinking about some kind of checklist and structure. But I don't think that makes it unimportant. And I think sometimes we need a structure in order to make sure that we get the right answers and that we've considered all the different options. So because I think that in crises, often people are quite stressed, we've made it really simple. As you can see, we've used the alphabet to make the ethics slightly less scary. And the first step is to assess the situation. So think about the information you need. And Paul, when he talks about the examples that we have, you'll see that sometimes that information comes from the clinicians themselves. Quite often, we need to think about other members that might be bringing the query. So sometimes there's debate between two clinicians about the right thing to do. Sometimes it's important, often, in fact, always, I think I would say it's important to find out what the patient or the relatives think. We need to consider outside in terms of what the societal perspective is and make sure we really have all the information and anybody can have the opportunity to present that. It is always worth, and I say this to the medical students too, considering what your gut reaction is to the problem. And the reason it's important is not to then follow your gut reaction, but to make sure that you have insight into what your reaction was to this. And then you can subjugate that gut reaction and don't just go with it. You're then going, okay, I'm aware of what my bias is. I'm aware of where I started. Now I need to think about this logically. And then I need to come back and say, well, what was the foundation for my gut reaction? Was there any, or do I need to go to something else? Obviously, you need to consider conflicts of interest of those present. And then Rob is going to talk to you about his role as a lawyer, but the relationship between ethics and law is very interesting. And law provides a baseline and for what we absolutely must do, but often there is an ethical prerogative which is higher than the law. So we need to make sure we're not breaking the law. We need to make sure we're standing by the law. But then I think ethics, and Rob and I have talked about this a lot, can add something extra. And actually, sometimes the professional regulations are higher than the law. So a very good example of that recently was the Montgomery judgment, where the law, the GMC guidance said you must communicate with patients all the treatment options and the risks associated with those. But until the Montgomery judgment came in a few years later, that was not the law. So the law kind of sometimes catches up with professional regulations or with ethical mores. So we need to be aware of the laws of professional regulations, but hopefully we're going one step further. Although I would say sometimes there have been ethical questions that have come to us that aren't in fact ethical questions, they're legal questions, and the answer can be given quite quickly. And then having got this information, we're then considering how to balance things. And this is just like this Ouija board, I don't mean that, this like tip-top board that you're trying to work out how you will make sure that you will balance the different values of the stakeholders and not being biased, again, to whoever it is that you know. So there are a lot of doctors initially on this group. We need to make sure that we're not just being biased to doctors, considering the impact on nurses, patient, family, everybody else. Consider the kind of standard 4 core ethical principles, which are from Beauchamp and Childress, so autonomy, avoiding harm, improving, making benefit, and justice, which includes benefits at individual and population levels. And you will see that some of the questions that came to us are about policy making, considering 3 other really, I think, critical principles, which are equity. So if we're making a decision that's a policy decision, for example, to move a ward somewhere or to start up a new process in the hospital or to create a new testing, is this decision going to ensure equity of care for different stakeholders? If in introducing it, are we going to create a risk of widening inequalities? How could we mitigate this? And is what we're doing potentially going to address and counter inequalities that already exist? So I think part of our job as ethicists is to make sure that the new policies that are being made not only don't create inequities, but also address some of the ones that exist. Is this going to be sustainable, or is this going to be a quick fix problem right now that's going to solve the situation for the next 2 weeks, but actually is going to set up much more complicated problems in a year or 2 years? And then can we be confident that we can communicate this transparently to those who are affected? And if we can't, it probably means that we're being too complicated or we're slightly uncomfortable with the decision we're making, which is why we don't want to go public with it. So we need to be able to be transparent so we can be challenged. And once we've come up with a balance for those things, then we're going to kind of check that our actions are proportionate, that our proposals do fit with the legal and professional constraints. We're going to consider how we're going to be able to evaluate our outcomes of our decision, and importantly, how we're going to justify a decision to whom and with what words. And then having done that, we're going to make a plan of action. So in some of the cases that you'll see, Paul, it's as simple as feeding back to the group that initially asked the question. But in others, we need to think about how we might change hospital policy. So we've been working with colleagues on for example, how we deal with the kind of moral discomfort that clinicians feel when they can't meet unreasonable needs that are being placed on them. Visitors who want to have extra time or come to other things. And then this important kind of feedback that if you don't think you're going to be able to deliver, well, you haven't actually done your job. Just having a circular argument, that's an interesting question, is not enough. And so you need to go back and start again and try and work it out. So if I stop sharing, I think I've probably hit my 10 minutes. I think I get a second bite at the cherry at the end to talk about how we might engage people further. But I will pass back to Paul unless anyone has any questions for me now, I guess, on the checklist, which we're thinking about changing the name for, because checklist makes it sound like it's a tick box. We introduced checklist, of course, because of Atul Gawande's checklist, but we're thinking of it. I think it's probably an ethical framework for approaching matters rather than a checklist.
Thanks, Zoe. Back to you, Paul.
So I'm going to share my screen again. And it's great that Zoe has outlined the principles behind setting up CEG and what we were going to do. But when I was asked to chair it, I don't think COVID had quite descended at the point at which I agreed to take this on. And then, like a lot of people, found that we had to try and set something up when our normal means of communication and the like were not available to us. But clearly, the first thing was actually to translate the ethical principles into a group that was actually going to deliver solutions, or at least advice as to how solutions might be found in an appropriate way. And the first thing was to recruit a group of people. We wanted it to be as broad as possible. We wanted to ensure that it would cover the areas in which ethics are likely to play a central role, so end of life, ITU, sometimes surgical decisions. We were also keen to have as broad a representation from within the trust, and we invited applications, and in fact were overwhelmed with a number of applications. But we also invited people to explain to us what their background was and what they thought they would bring to this. And I think we were very, very fortunate indeed to be able to assemble a broad, thoughtful, reflective group of people whom I've listed on the screen, which I hope you can see in detail. You can see that a lot of them are medical, but certainly not all of them. And we've had really useful input from absolutely everybody on the group. So it's invidious to single out individuals, but I will mention Tracy Brown as the adult safeguarding lead has been really crucial. Ben Clark, from whom we'll hear, has played a central role because of his role in palliative medicine. Richard Holton, who's the professor of philosophy in Cambridge, has proved adept at outlining some of the philosophical principles behind any issue we're discussing, and then honing in absolutely and with laser precision on how we can convert that into practical suggestions. We've had David Inwald from Pediatric Intensive Care, as well as Andrew Johnson from Adult Intensive Care, Ali Mackett from DME. Helen Manson is an established ethicist in her own right, and that has been very helpful. Jonathan Roberts, as a genetic counsellor, has already proved his worth on many occasions, not just in those areas that relate to genetics. We've had a trainee, Kirsten Scott, and we've also had useful, excellent input from several of our patient governors. So once we'd got it set up, we had our first meeting on the 18th of January 2021. And it was a slightly unusual one in that this was not a question from any particular clinician, but it came from the trust. And we were asked to consider the following: given the responsibilities we have as an acute trust to care for patients with COVID-19 and those without COVID-19, our responsibilities to the local population and our regional responsibilities both as a surge centre and specialist centre, can we ring fence or protect critical care beds for certain patients with all the impacts this will have on this acute and precious resource and implications for patients and their families? So it's nice to start with a relatively straightforward and quick issue to resolve. It wasn't, though, in many ways a bad one for us to start with. because we learned an awful lot from the discussions we had over several meetings about this. The first was that we needed to think a little bit more about how we would break down the questions that we were asked, because if we were asked to solve too broad a question, it actually became quite difficult to move forward. It was also clear that we didn't have access as the Cambridge Clinical Ethics Advisory Group to all of the information that you would want to address such a question. And indeed, it would probably have been difficult to do this even at a national level, given the rapidly changing prognosis of those with and without COVID as the pandemic wore on. Some of the non-COVID cases waited longer for their treatment, and so their priorities increased. So we had several goes at producing an answer to this, and indeed we did. But the main thing that we learned from it was that we needed to improve the questions that we asked when people were referring to us. And we condensed it down to ask people to outline the issue that they wanted us to consider. We wanted an outline of the current situation and the possible ways forward. We wanted a summary of background information, including advice sought from other sources, and any specific local or national policy shaping your practice on this matter, because what we clearly didn't want to do was to produce something that was different from other groups considering the same question in other places. We wanted to know who was going to be affected by the decision and what their views were, and then we condensed it down to a specific question that we wanted CUH to address. Feedback I've had is that it's often rather helpful to people as they are filling this out. On occasion, indeed, it's that the reflection that's required to complete this has indeed led to a possible solution, so it's not even come to the committee. But certainly when it's come to the group, we've been able to make better progress. And then over the last 2.5 years or so, we've had, as you can imagine, a significant number of individual cases. We've also had some that are more general. So we were asked quite early on about the ethics of prioritizing neurosurgical patients down here in the orange one. One that came in that was related to COVID was brilliantly put together by the neurologists and NCCU. In the absence of capacity, how long should a patient be kept on extremely challenging treatments? We've been asked quite a few questions about when it's appropriate to end treatment, particularly where that involves something more active, like removing a tracheostomy. We've recently had a patient with previous ITP complicating a rather traumatic delivery who was declining most input, plans for discharge, whether it's appropriate to offer a kidney transplant. And I don't particularly today want to go into the details of each and every one of those because they are specific details, and often our recommendations are relatively long and include a number of options to be considered, because we are not a deus ex machina coming in to tell people how to manage cases. We're there to try and help people, particularly where there's conflict. But I'm going to reflect on a few things. The first is, in a time when everything is on Teams or Zoom, how do I, as chair, ensure that we have valid input from everybody that's contributing to the group? How do I ensure that the members of the group also listen with respect to each other? And it's actually quite useful that you can have an electronic hand that goes up with the order so that actually we're not all talking over each other, which is really important when we're considering some of these very difficult, very finely balanced, conflicting interests. We've also had to address how we involve patients, most of whom may not be familiar with what the idea behind a clinical ethics advisory group is, and how we do that in a way that's not threatening for them. And I'm very grateful here to Phil and Zoe in the sort of pre-meetings that we can have with patients, so that they are not as alarmed when they come to present in front of the whole group. We're thinking how we can better involve relatives when patients can't speak for themselves. But another thing that's very much emerged from so many of these discussions is actually the other things that crop up the things that we as a body need to be thinking about. Zoe already mentioned the moral hazard to staff being asked repeatedly to go beyond what's perhaps reasonable to expect, the drain on them, and the things that we need to put in place to support staff as they deliver care for patients. So it's certainly been a very interesting job, and we are all learning on it, both from our own experience and of course from others. So I'd be very interested to have first Ben Clark, then Rob Tobin, and then Phil Sharkey as 3 members of the group speak for a couple of minutes each about their experiences and what they've learned from participating so well in this.
Thank you, Paul, and thankfully I don't have any slides to put up, so I'm not going to need to wrestle with tech, but I would like to start by just paying tribute to Paul and to Zoe, who have so expertly and energetically and skillfully pulled this group together and helped navigate us through the first couple of years of this formative process, and so brilliantly supported patients and families and staff members alike, along with all of us, in getting us to the point that that we're at now. And I don't say that just to be sycophantic. I say that because in the spirit of comparison, and while there's a saying that comparison is the thief of joy, in this instance comparison for me here is very much the source of joy, having been a part of an ethics committee in another trust in the east of England and the vice chair of an ethics committee in a trust down in London for a few years, where part of our challenge was getting engagement, not just from clinicians, but senior clinicians, as well as getting appropriate and complex cases for referrals that in other places has been a real challenge. Here, Paul and Zoe have made that seem effortless. And one of the things that struck me first when I joined the committee in the first meeting was how exciting it was to hear that there wasn't just a small number of senior clinicians, but a large number of quite competitively applicants who wanted to be a part of this committee. And I think that says a lot about the consultant community within this trust and the wise, broad-minded experts that we have within this trust. And that impression, as a new boy to the trust, as I was back then when this started, has just been reinforced with every meeting that we've had. And every committee meeting has been a learning exercise. I think one of the challenges as a clinician on a clinical ethics committee a clinical ethics advisory group, is parking our clinical knowledge to a certain extent to allow us to focus on what really the ethical questions or problems or issues are, and then saving that clinical knowledge and insight to inform what it is that we're saying. And it's that process of discussion from different experts, and Paul has already listed the breadth of specialist expertise that we have around, that for me at least don't just make me give me a more helpful contribution to the discussions of the different cases, but actually gives me something to take away and makes me a more knowledgeable clinician outside of the group as well. And I very much hope that in some small ways at different parts where I've been able to contribute to the discussions, that learning has gone both ways, because certainly it's the case that the cases that we've had to discuss and consider have covered the entirety of life's journey, from the prenatal to the genetic, right the way through to the last years and months and weeks and days of life, which is where I fit in and contribute most, I suppose. But I think that the other things that I would reflect, and this is something as well that resonates with my clinical work in palliative care as well, is that it is very often, it is not so much the concrete problem, the clinical problem, or in my work, the symptom that brings cases to us. It is how people are feeling about them. And it is that either emotional distress for patients who are either distressed or distressing or both, or for staff, that sense of moral distress that Zoe was referring to earlier on. It is that challenge that in part an ethics advisory group like us really feels like it has a role and an importance in providing another essential part of making sure that not just our patients and their families are getting the best decisions and the best input and the knowledge, the specialist knowledge and advice, but our colleagues are as well, and are having that security and reassurance that the problems that they are wrestling with because they are difficult. And a lot of the cases that we consider are times where there is no obvious right or wrong, it feels like, and there may well not be a right and wrong. And sometimes I think that my take home from some of the cases that are brought to us is oftentimes it doesn't feel as though they are clinical problems to solve, as much as they are really morally distressing situations to be managed ethically. And it has been a real privilege to me to be a part of some of that solution over the last couple of years.
Thank you. Rob.
Thank you. I won't repeat a lot of the things that Ben said because I completely agree with everything. And one of the privileges I've had is just to hear from so many different people with so many different backgrounds, not just medical, but as Paul said at the beginning, the chaplaincy with Phil and philosophy and everything else in between. So I'm the lawyer in the group, but it's quite intimidating because most of the group know significantly more law than I do, it would appear. But I come to the group to explain what can and can't be done, and sometimes what the judge is likely to say should or shouldn't be done, as much as we can. So usually I'm acting for the trust, and I'm at the end of the phone call answering sometimes an emergency treatment decision call from usually on a Friday night from someone in ED or in intensive care, discussing whether or not certain treatment should or shouldn't be given to a patient. And I'm there to provide the legal analysis rather than any kind of decision making. The privilege we have in CUH is having the time to explore some of these issues, because at the end of the phone call on a Friday night, there often isn't that time to have those discussions. And it's a privilege to be able to hear from many people, including, as others have said, the families and the patients. And in the life of CUH, we've had the William Burden decision, which was decision last year, concerning a Manchester case where a kidney transplant patient, age 17, there was a discussion about whether or not he ought to have a transplant, and one of the aspects of that judgment was that it was vital that families and patients are involved in these clinical ethics advisory group discussions. So it's great that we follow that. I suppose a couple of reflections on cases that we've been involved in, and some of them have been alluded to. One of them was a case of AH, which attracted quite a lot of media attention, and it was incredibly important to have the support of CUH in that case. That was concerning a patient in her 50s who was described as having the worst case of COVID, or the consequences of COVID in the world, and she was in intensive care on a life support respiratory machines for almost a year. And the hearing from the family, and I suppose the ethical blurring of the legal ethical blurring of decision making really struck me in that case, because you had the apparently straightforward question of what is in the patient's best interests, but here you had the family saying that they wanted their mother, loved one, sister to be kept alive at all costs, and they were saying that it was in her best interest to be kept alive because that's what she would have wanted. She would have wanted her family to have her alive, be kept alive. And so you get and sometimes there are no answers to these questions. It's not a binary decision, even though in the law it does become that. So the nuances that are really exposed in CUH are fascinating. And we had another one fairly recently called RD. Well, in the law it's called RD, but we had a different initials for the patient concerning someone who consistently self-harmed quite severely, severely damaged her trachea. And the question for us in the ethics committee was whether or not it was in her best interests to not save her life next time she attempted to self-harm. And as Zoe has said, the moral hazard for staff in that case was profound, because the impact of staff in standing by and not saving someone's life when technically they could was incredibly significant. So that's just some of my reflections. Thank you.
Thank you, Rob. And I don't think most of us know more law than you, but we're always grateful when we can help things avoid coming to the law, but it's really useful to have the legal input. And also, Phil, your role as part of the chaplaincy team, I'd like you to reflect on that, please, for a couple of minutes.
Yeah, thank you. Yeah, I mean, the particular case that of the patient who was on life support for a very long time is the one I think that most challenged us. In chaplaincy, we're often called in to support relatives and family when the decision to withdraw treatment is being debated and discussed. And I think that it's been very helpful to be able to kind of bring some of that experience. I also come from a background where I was in the past managing social work in both a mental health context and safeguarding. What I've learned from some of these things, I suppose, is how this group has moved on itself and learned the idea, the decision to involve the patients and family in our discussions at the earliest stage certainly has borne fruit. It was helpful with the patient who didn't wish to have anesthesia when she came in, if she had to come in for the birth of her second child because of a whole variety of issues, including some traumatic stress and other issues that were presenting to her, and her express wish being that she would rather die and give life to the child than undergo a similar experience. So that was a very difficult one for us to think about. I've recently been helping some staff on one of our wards in C7 to frame a referral that may come to us shortly, and that again is what is in the best interests of some quite difficult young people who we're getting to deal with there, for whom we are administering treatment that is saving their life, but is very much against their will. And I'm thinking again of the other young lady that we saw. I think for us, part of it is to be happy to be as specific as possible in the referral. What is the ethical dilemma being presented, and for whom, and who owns that dilemma, and what choice of freedom do they have in it? And also, I guess going back to the whole real debate about what is in the best interest of the patient in all this, and who can make a judgment when they don't have capacity. Those seem to be the issues that we all struggled with. In some ways, what we in chaplaincy have is that ability to be devoid of clinical knowledge almost, but to have that kind of helicopter view of seeing where all the interests of people are playing out, because we're coming at it from a different perspective. And one of the concerns that I did feel with the particular case, I think it was RD, the first case that Rob mentioned, was the harassment and bullying behaviour to staff that was being experienced. We did write some recommendation and guidance to the trust senior management about how we might protect situations like that occurring again. We had the family of the particular patient finding all sorts of different and questionable and illegal ways to gain entry to the patient, and to disregard the rules on how many people should be visiting her. And we see this from time to time, but there is a gross effect on all those other people who are receiving treatment, the other families who are there as well. And I did have the great fortune or misfortune to be on call over this weekend when there was a very similar scenario, withdrawal of treatment in NCCU, where there was a couple of very difficult family meetings before we made that decision. And we had 60 relatives coming through the hospital many of whom were camped in our chapel as we waited for that patient to go forward. So it's that kind of balancing act I feel that we've also been able to see and have some involvement with.
Thank you very much for that, Phil. So I think you've all had a flavour now of the variety of cases that have come before us, both individual cases and more strategic things. I feel also that this has thrown up some other matters to be considered by the Trust. Zoe, I did want to give you just 2 or 3 minutes to talk about how we're thinking of developing in the future before I summarise and give people a chance to ask questions and have a wider discussion.
So I think the things I wanted to say are to add to that discussion, really, to say, I think we're now established in terms of a process for people making the referrals, a process for us discussing them, and a process for us feeding back. I think there are many, many more ethical issues going on in the hospital than the number that are being referred to us. And that applies to both just the individual issues between clinicians, or that the clinicians are facing, but also in terms of policy decisions, or in terms of how we make wider decisions across the hospital. And so my question is, how do we lower the threshold for people to make those referrals? How do we get out there and have discussions about that? And then the second part was, I guess, that one of our aims was to improve the ethics teaching. And we wondered about doing things like having an ethics cafe in the concourse where people could just talk about problems that had perhaps troubled them a little bit, maybe that didn't quite meet the threshold for referring to us, but that they wanted to talk about, and just get the language of recognizing that a big part of what we do is make ethical decisions into general discourse among both junior and senior doctors. I think the junior doctors are now taught ethics. I know they are, because I teach the medical students, but I think a lot of our senior colleagues weren't. And I think actually some are a little bit scared of it. And I think equipping them with the language and getting them working would be helpful. So ideas from people on the call about how we might do that. We've talked about perhaps taking a grand round. We've talked about, I think some debates would be great in the hospital, maybe even taking a debate and using it as a grand round if we could manage that. I mean, taking a grand round and using it as a debate. But ideas on how we can, I guess, disseminate and improve the general ethical thinking among our colleagues, as well as the specific questions.
Thanks very much indeed, Zoe. So I'm just going to summarize by saying we have been born, we have survived, we are looking to develop further. It's relatively easy to find details of us. If you go on Connect and type either CEAG or ethics, you will get taken straight to our page where we have the referral form. I think we make sure that we've got a list of the members of the group there as well would be a good idea, so that people are welcome to approach one or other of us informally to work out how to move things forward. So don't forget that we are here. I want again to pay tribute to all who've made such a contribution to this process during difficult times. Every single member of the group has really played a part. But above all else, I want to thank Charlotte Collick, who is the Trust Secretary, who has done a fantastic job of producing minutes. We agreed from the beginning that we would use rather Chatham House rules. So things are well documented, but not attributed to individual people, because I think that would be a break to people offering views of what they felt. But they are all recorded. We do all come to a consensual view. And although it's been challenging to chair the group, it's been extraordinarily rewarding as well. Very keen to have questions. So Justin, I presume you will chair the questions session.
Thank you.
For us.
Thanks, Paul, and thanks, Zoe, Ben, Rob, and Phil. Thank you very, very much for your contributions. Just whilst some of the people are perhaps thinking of questions, and do please raise your hand if you'd like to. I'll just make a point of reminding those who are watching this back on record, which many more people will than those who are present, to perhaps be in touch with Paul or Zoe if they, having watched this back, have thoughts or ideas that they think could answer some of the queries that you just posed there, Zoe. So just for other people to get in touch with you directly. Just a quick couple of questions from me, if I may, and apologies for perhaps I should know the answer to this, but I mean, do you meet on a regular basis, and if so, how regularly? And I presume you have criteria for needing to meet on a more urgent ad hoc basis if required. Is that correct?
Absolutely. So we began by thinking we would meet regularly every 2 months. Then we reduced that to every month. Then it's gone back up to every 2 months. And indeed, sometimes we haven't had business at those regular meetings because we've seen a shift towards more of the urgent referrals. And it's outlined. So if people, we can convene a group within 5 working days, within 3 working days, I think we try to. We've obviously got to get a group of people together. We have rules about the quoracy of that. If somebody's not sure, is this a matter for a regular meeting or an urgent meeting, that's something we can certainly provide advice about. But you're absolutely right, Justin. There are regular meetings where we reflect on what we've learned and the procedural changes more now than, but then there's urgent meetings to consider individual cases.
Thank you, and it's clear from the breadth of members of the group that there's lots of expertise present. I guess one of the questions that I would pose would be things like, for example, EDI and the issues that are important there, perhaps to some of the cases. Do you import in other expertise if you need it? Do you have specific people within the group that for example, address these sorts of things? How would you play that?
So absolutely, we had more applicants than we had places for on the group. And so we have a list of people that we can call upon in specific circumstances.
Annalisa is on the call. She's one of our people with the genetic expertise. So yeah, spotted her.
Well spotted.
Julian, I wouldn't want to necessarily put you on the spot, but I would just ask how you might sort of, whether there are any reflections or issues that, or I guess thoughts on how the individual sort of ethics groups within the trust kind of feed into the more the overarching ethical approach of the ICB, for example. Are there any particular reflections on that? Things that we do really well, could do better, don't do at all? Thoughts there? Sorry to ask you specifically, but I'm well aware of your interest and expertise.
Well, thank you, and it's an honour to be a guest at this. So thank you very much for letting me be here. So I used to be deputy chair of the CCG, and now continue to chair the System-Wide Ethics Committee. It's fascinating to see how this works. Now, we are very fortunate that the vice chair of the System-Wide Committee is Dr. Zoe Fritz, and so we've been able to make sure that there is a good link. Some of the questions we have discussed at that level as well, and it's really interesting to see the difference. We take a slightly different legal lens, for example, because we're never dealing with specific patients. And so it's really interesting to think through. So what we're trying to do is provide comments and advice on system-wide issues or advise where there isn't something else. But it would never be, here is a patient, this particular patient, what should we do? And I'm frankly quite delighted that we don't try to do that without that sort of expertise. But it is interesting because what I hope we're trying to do is to also think about the resource allocation questions. So not just to say, given where things are, what should we do? But also to think much more broadly about how things should be. So at the moment, we looked at 3 issues at the last meeting, one of which was about the ethics of smoking cessation, whether it should be a requirement before operations, which again is a sort of system-wide challenge. It's not unrelated, but dealing with some of those issues. There was one issue about what to do when you have different ethical decision makings for different groups. If the NHS thinks something is ethically wonderful, but for example, local authority doesn't. And again, that's a nice system-wide example. And the one I'm leaving to last, because it's one that I hope some of you might get engaged in, is that PA Consulti are currently doing some work for across the whole system to devise a new strategy for reallocating resources, particularly to tackle health inequalities. I don't know how many of you have been involved with some of that, but there's a lot of quite detailed logic model work they're doing. We haven't finalised our report. I'm waiting for comments back by tomorrow. My candid view is that they've put health inequalities in the title and then forgot to mention it through the rest of the strategy. If any of you have seen that work, feel free to disagree or agree, but you might want at some point to engage with some of that, because I think it will have a material impact on a lot of what you do as consultants and what you do in the Clinical Ethics Committee. So I hope I didn't even get supper and I had to sing, so I hope that was useful.
Very useful context as well to understand the different overarching sort of things that you're also looking at and how they might gel together. So thank you for that. That's very helpful. Any questions that anyone else?
Certainly it
Sorry,
has
Paul,
been
please.
extremely helpful that Zoe has been part of both. And I think, Julian, you've nicely outlined how I think we will overlap, but you know, there is complementarity. And just as you're somewhat relieved that you're not thinking about individual cases, I'm somewhat relieved that we're not all of the time trying to think about big strategic questions where we don't necessarily have the information that we would require. But I'm very keen that we try to become more joined up, and I've certainly had some conversations with the corresponding group in Royal Papworth Hospital, and we're certainly sharing some ideas because that's important. Whilst I don't want to, I think it's quite good for them to have a separate ethics group to consider some of the issues there.
And presumably NWAFT would have a similar group too, Paul?
I've learned over the years not to make too many presumptions about NWAFT, but Zoe might know better.
Yes, they do.
Great, thank you.
I think they set it up fairly recently.
Great. Well, look, that's good to hear, certainly from an ICB perspective. I don't see any other questions. I'm aware it's the evening and it's 5 to 7. Paul, I'll just ask you if you or any of your speaker colleagues have any other comments or queries you'd like to add before we perhaps come to a close this evening.
Really just to thank the attendees who've sat out all our technical glitches. I hope it's been interesting for you all. And we're very conscious that another thing that we've got to do is to put in place a strategy for renewal of the group looking into the future. And there's that delicate balance, isn't there, between being on the group long enough to get the experience that makes you an effective contributor. So we wouldn't want people only on it for 6 months at a time, for example, but equally not that it's not open to new members while still keeping the size a sort of manageable size. But no, thank you for the opportunity to present, and thank you to everybody who's listened. And absolutely, we're all available for people to get in touch either about individual cases or ideas for the future.
Thank you very much, and thanks to all for contributing this evening. Really very interesting session, and as I say, the recording will be circulated to the consultant body. So thanks very much indeed. Have a good evening. Good night.
Thanks. Cheers.
Thank you.
Thanks, Paul.